Okay, thank you for joining us today. My name is Alexandra Vincent. I'll be the moderator today. I'm also one of the co-chairs of the Learning Health Systems Collaboratory. Today's session will be recorded, and the slides in the recording will be available on the Learning Health Systems Collaboratory website archive. And for those of you who've joined us on Zoom, we request that you keep your mics muted. This will help us capture the presenters clearly. And then at the end, when it's time for the Q&A, please put your questions in the chat. If you are claiming CME or CPD today, this is your QR code to scan with the activity code. And as part of our theme this year, we're looking at articulations of the value proposition of the learning health system. And so in its own way, each one of our talks will interface with that theme. By the end of the year, we will have explored a number of different ways of talking to various audiences and coming up with explanations for why the learning health system could be valuable in an institutional context, in a specialty context, and talking with audiences like patients and family members, like administrative leaders, et cetera. And I want to acknowledge my co-chairs, Chuck Friedman and Ed Hurvitz, who's a panelist today. Here are some of our learning objectives that motivate our activities together this year. So today we have a presentation called LHS on the Frontlines, 2 case examples of thriving together in M-Integrate. So our rough agenda is that we've kicked off. I'll do introductions shortly. We'll have the presentations, move into a Q&A, and wrap up just before 1. So these are our 3 speakers today on the panel. We're really excited to have them. Our first speaker is Dr. Elizabeth Harry. She's the Chief Wellbeing Officer for Michigan Medicine and a Clinical Associate Professor of Internal Medicine and Learning Health Sciences. Appointed to the CWO role in November 2023, she leads the Office of Wellbeing in designing data-informed, system-level strategies that foster a culture of professional fulfillment and reduce burnout across U of M Health and the medical school. Previously, Dr. Harry served as Senior Medical Director of Wellbeing at UC Health and Assistant Dean of Faculty Wellbeing at the University of Colorado School of Medicine, following earlier leadership roles in faculty development and wellbeing at Brigham and Women's Hospital and Partners Healthcare in Boston. A nationally recognized authority on cognitive load, clinician burnout, and workforce redesign, she's delivered dozens of invited lectures, published seminal research on physician task load, and sits on the board of the Collaborative for Healing and Renewal in Medicine, while teaching in Stanford's Chief Wellness Officer course. Dr. Harry earned a BS in Psychology and Biology from Santa Clara University and obtained her MD and completed her internal medicine residency at the University of Colorado. Welcome. Dr. Raj Mangrulkar's work focuses on organizational leadership and innovation, transforming education at scale to advance the social good. In 2021, he was charged by the University of Michigan Provost Office and Health Sciences Council of Deans with building an innovation community of practice across 3 campuses to transform education so that health improves. He holds 2 roles to help foster this goal: Director of U of M's Center for Interprofessional Education and Practice, and Executive Director of RISE, a health sciences education innovation initiative that he founded at Michigan Medicine. Dr. Mangrulkar is currently actively involved in helping other U of M schools and colleges, as well as other institutions, transform their education programs at scale through change management, training, and development, more recently collaborating with the AMA and the Foundation for the Advancement of International Medical Education and Research. In 2022, he was awarded the Robert J. Glazer Award for Distinguished Medical Teaching by the Association of American Medical Colleges and the AOA Honor Medical Society, the highest national award given for medical student education. In 2024, he was inducted as a Distinguished Fellow into the National Academies of Practice. And our final panelist, Dr. Ed Hurvitz. He's a professor in the Department of Physical Medicine and Rehabilitation and in the Department of Learning Health Sciences. He specializes in the diagnosis and management of pediatric onset disabilities, especially cerebral palsy. His research focuses on adolescents and adults with CP, including areas such as health and fitness, pain, and health-related outcomes. Dr. Hurvitz served as the James W. Ray Collegiate Professor and Chair of the Department of Physical Medicine and Rehabilitation from 2006 until early 2024. He has held several national leadership positions, including chair of various committees for the American Academy of Cerebral Palsy and Developmental Medicine and the steering committee of the Cerebral Palsy Research Network. Dr. Hurvitz currently serves as the Michigan Medicine Learning Health System Clinical Champion. In this role, he's working collaboratively to increase awareness and adoption of the LHS methodology at Michigan Medicine. And as I mentioned earlier, he is one of the fabulous co-chairs of this Learning Health System Collaboratory. So we couldn't have a more esteemed panel with us today to talk about some important ways of mapping LHS concepts onto institutional initiatives here at the university. So with no further ado, I will hand it over to our panelists. Thank you so much. Thank you. You're welcome. Clicker has been a little funky, but if you have any slides right now.
Perfect. Well, hi, everyone. Thank you for having us. So I just want to take a moment really quickly to step back and sort of explain what our office focuses on in three main buckets, and then which bucket we're talking about here today. I want to acknowledge that I have a little bit of imposter syndrome because I'm going to explain how we're trying to implement learning health systems to like a bunch of learning health systems experts. So this is meant to be more of a dialogue, share how we're trying to think about this, and I would love any feedback that you have or areas of opportunity that you see. So our office, the Office of Wellbeing, is really designed to support the professional fulfillment and thriving of all 35,000 folks in Michigan Medicine. So whether you are working, learning, educating, researching, delivering clinical care, all of the above, anything I didn't mention, we're here to support you. And we think about that through three main buckets. So the first is, how do we do our work? And this is where the learning health system comes in and integrate in what we're trying to build. And I'm going to talk to you about that. And is the camera online? Is that like a problem or it's okay? You got it. Okay, good. The second bucket is, how does it feel to work here? And this is where we get into the culture work. Our office, with the Office of Health Advancement, co-sponsors the Belonging Initiative. That is not what we're talking about today, but if you're interested, and I hope you are, you can check the Belonging Pearls that have been coming out every week in headlines, because we're giving little snippets of activities that you can use to enhance belonging in your teams. Lots of other things available in that space. And the third bucket is personal resilience, or what skills do you and I have to cope with the difficulties in the systems and the difficulties in the culture as we work to change them, recognizing that these are hard things to change. It takes about 5 years to change a culture, as we know, and it takes a long time to change operations, particularly those that are well entrenched. And so we all need good skills to be able to manage ourselves, bring our best selves to work, and we have a personal resilience sector for that. So we have three main focuses of our office, and we're talking about one today, which is the organizational improvement. How are we helping people think about the pebbles in their shoes, the boulders in their back, the operations that make it more difficult for them to do the things that they're trying to do? So this is a visual of how we've tried to think about bringing the principles of learning health systems into our office to build this integrate model. And I'm going to talk to you about what this is. But the goal here is really to build a concierge front door to create access and help for people that need it, teams that need it. And then how that building that sort of value and that structural underpinning integrates with building strong learning communities, which then leads to our partnership with Raj's team in Thriving Together and the practice redesign that they're doing with the Center for Interprofessional Education. So this is really a partnership between these two groups where we're really trying to think about the nuts and bolts of the operational piece, and partner with our Center for Interprofessional Engagement around how we can build really high functioning, high quality teams. So now we're going to focus just specifically on the integrate part of that and sort of explain what the vision there is. So this is the Michigan Initiative for Navigating Team Efficiency and Growing, and sorry, there's a duplicate in there, Growing Resilience Across Teams. So I don't have to tell you all this, but this is, our classic sort of learning cycle, right? And the idea here is that we want to iterate, and we want to iterate quickly. We want to be able to go into an area that is having a hard time and quickly be able to help them understand things that they can do practically and very tactically to improve their outcomes. The problem is right now, things are incredibly fragmented. So Raj always has this beautiful way of describing the way we're organized, which is that we have all of these vertical areas that have a key deliverable, right? Like this is the division of pediatric rheumatology. Their job is to think about this very specific area, right? And they have to keep the lights on, and they have all these other things. Then we have all of these groups of us that are sort of horizontal, right? That we touch all of these vertical areas. The Office of Wellbeing is one. The Center for Interprofessional Education is another. I would say Learning Health Sciences is another. But there are many, and we'll talk about several that we're partnering with that are sort of horizontals that touch many of these vertical areas. So we invited a lot of these horizontal areas to come together, and we said, well, why don't we sit down and talk about, like, what do you do and what do we do, and is there overlap, and how could we work better together? And we started talking, and we found one particular area, one unit that was struggling. And everybody in the room raised their hand and said, within the last year, we have been invited to go there and help that group. So if you think about this, I want you to think about how we used to deliver care to a kid with complex cancer. We would have that kiddo come in, and they would see the oncologist on one day, and they would see the radiation oncologist on a different day, and they would see a different medical specialist if it was an endocrine tumor on a different day, and they would get labs maybe multiple times, and they'd have to go to radiology multiple times. And in addition to the burden of trying to manage this disease, trying to cope with what's happening, they have a lot of administrative burden of getting to and from our institution and finding parking and finding radiology, and the poor kiddo's got to get poked, right? And where did we go from that? We said, well, no, best practice is that that child and their family comes in and they sit down, and we come in and we work around them, right? Each specialist comes to visit them. We give them back-to-back appointments. We get clarity on all the labs we want. We do it once. We get all the imaging done ahead of time. We have all the information we need. We give them everything they need, and they get to go home and now still cope with the challenge of what they're experiencing. We want to give this same level of service to our teams that are asking for support. And when we sat around and we talked about this one area that had asked every one of us for help over the last year, we had all popped in and out of this area for different reasons, because we all wear different hats in these sort of horizontal spaces that we sit in, right? And we had all given them different recommendations, because we're all wearing different glasses or different hats when we think about this, but to the same end, right? So if we think about the quadruple aim, if we think about the quintuple aim, we're all trying to get to the same place. And the same problems are driving a lot of these issues, right? So the reason that there's a safety issue is probably one of the same reasons that maybe there's a team culture issue, and maybe it's the same reason that we have a burnout issue and providers are leaving, and maybe it's the same reason the patients aren't having a good experience, and so on and so forth. And so could we organize ourselves a little bit better? Could we think about that care experience that we have defined as best practice and offer that to our teams that are asking us for help too? So that is our goal, to build an infrastructure of integration, to bring all these teams that already exist together, create a single front door, a clear inventory, and then a clear assessment and plan. So our goal is to connect. So turns out we have a lot of services, and I'll talk to you a little bit more about that, but part of our job has been an inventory of, like, well, what's available? And it turns out that there's a lot that's available to help people, to simplify. So if you're in distress, if your unit is in distress, knowing where to go and what to do can be really complicated. So let's make that easier for people. And then a clear evidence-based intervention. So we're going to do a diagnostic assessment that's evidence-based, then we're going to make a recommendation, and then we're going to work together to help you do this. And we're going to do it quickly. We're going to iterate rapidly. So we decided to bring several sectors together to start. Now, I want to be super clear that there are a lot of horizontal groups at Michigan Medicine. And this is not an exhaustive list. And it is not an exhaustive list, not because anybody that's not on this list is not incredibly important and the work they're doing is not incredibly important, but just because we had to start somewhere. And it's hard to get a lot of people at a table together and get yourselves organized. So this is where we started, and we will continue to grow. But the first sector is really thinking about, okay, well, there's a lot of us that are cultivating well-being and resilience, and coming in and helping teams think about their well-being and resilience. There's our office, there's the Office of Counseling and Workplace Resilience, and there's Health Advancement. And so we said, well, let's all of us try to get together and think a little bit about, like, what we're doing in our diagnostics and our assessments. There's another sector where they're driving workflow and system excellence. And this is the Center for Healthcare Engineering and Patient Safety, otherwise known as CHEPS, and our Quality and Safety Office and our Office of Clinical Informatics. They're going in and they're helping people like really look at the design of how they do things and how are they integrating with the EHR and what do their order system look like. And then we have a sector really trying to accelerate learning and professional growth, making sure that everybody in this area understands what's available for them. The Department of Learning Health Sciences, the Center for Interprofessional Education, our Office of Patient Experience, right? Trying to make sure that everybody's equipped. So we brought all of these groups together and we said, okay, how could we do these things that we just talked about? Connect, simplify, and support. So one is we're going to have one front door. So what would it look like if we put all of ourselves behind the same front door? So there's a bit of a more concierge experience, right? The same idea of that kiddo coming in and sitting in one clinic room, right? They're not running all over. They don't have to call all the people. They can just sit in one place. We're going to have a simple diagnostic assessment that is evidence-based. And we reached out to the School of Public Health. One class took an entire semester to make an evidence-based assessment for us. This was the outcome of their semester for us, which is why I love the University of Michigan and our opportunity to work together. And then how are we going to support? So we'll do these expert-led sprints. So the beginning of this then is the single front door idea. And so this is the beginning, and this is not live yet. You can't go see it yet, but this is our back-end version of our SharePoint that we are building that starts to catalog all of the services available. We've already found 90 services, 90 plus services available that you are a unit, you're having a hard time. There's 90 services that can come support you. You can just, if you want a self-service, you could go onto this and you could filter by category, you could filter by role type. We've put it in all these filtrations. My goal is that we can augment this with some AI and there could maybe at some point be some sort of conversational capacity. We have 2 diagnostic assessments, one for frontline and one for our leaders, where you can take a test and we will tell you, you know, just like a personality test, you go here, this is actually what your unit might need, right? And these are the resources that are available. So this can be an asynchronous thing that people can do on their own, or we can engage with them in doing this as well. Things that are in our workplace stressor assessment are there inefficient workflows? Are there staffing and resource issues? Role clarity and teamwork issues? Issues around inclusion and belonging? High cognitive load? Ineffective leadership and management? I want to be super clear that we are not fooling ourselves to think that we can solve all of these issues. So if we learn Unit X has a staffing and resource issue, I do not believe that we necessarily are going to be able to provide the staffing that they need. But what we can do, because we are a learning health system who's trying to learn, is we can collect data on like, hey, did you know that 80% of our units that are reaching out to us are having a staffing and resourcing issue? And we can share that with people that can be impactful in that space. So part of this is really trying to understand and collect the data. I'm sharing this with you because we had really intentional dialogue about should we include things on the assessment that we can't fix ourselves? And we sort of decided, yeah, I think so, because I think we can give the data to other people and that can be helpful. So what has our journey looked like so far? We actually started this almost a year ago, just bringing people together. And I have to be honest, there was a little bit of like, wait, you do that? But we do that. That's like our swim lane. You're doing that too? And there was even a little bit of like, oh, I don't know how I feel about you doing that, right? And we had to do our own team building and our own sort of, well, what would it look like to understand that we are better together, that we can be more impactful, we can be synergistic if we stop duplicating and replicating one another's efforts. So that was a big part of that. We got clear on like, what is our mission and vision? And then started building this directory of services, which was a really big lift to try to get clear on that, created this SharePoint site. And then we got the diagnostic assessment tool back from our students, which I'm so grateful about. And then we have that up on the site. And we actually have later today, I have a meeting with our first pilot site, which I'm very excited about. So we have our first pilot site today. We have another one potentially in the works. And then we're going to start iterating on this. So if you happen to know of any good pilot sites, please let us know. So looking forward, we have this pilot kickoff, and then we're going to start socializing this. We want to be a little bit careful here. And I think this is interesting, right? Because what you'll notice is nowhere during this time did I say, and then we secured a grant for $5 million, right? We have asked for $0 for this initiative. And the reason that we have done that is because we're all already doing this. Like we basically just said, hey, this is our day job. This is your day job and your day job and your day job. I bet we could all do it better if we did it together. and let's just bring our offices together and try to do this a little more organized. And what's been interesting about that is as we've talked about socializing it, some of the groups have been like, okay, but I'm not sure we can actually like handle the capacity of everybody knowing that we have this resource available, which is also super interesting data, right? Like we have systems and services that are in theory available to everybody that maybe we can't actually, withstand the capability, the capacity that might be coming our way. So we're going to be a little bit careful about what our marketing looks like as we continue to pilot this. And then we ourselves are going to be a learning health system. So have continuous improvement. It's probably going to be really messy at the beginning, and that's okay. And we're going to learn through it, and we're going to keep iterating. And my ask and invitation to you is that anyone that wants to join our learning community, we are modeling it. We're learning so much from Ed. Ed is a key leader in this. We're modeling it after the concept of learning health systems, and we would like anyone who's interested in joining us to join us. So this is a really grassroots effort. This is a QR code that should take you to the SharePoint, and you should be able to see sort of a draft version of it if you're interested. And then if you have any questions, please email us, and I will leave you with then this vision of really then how we are taking this infrastructure piece and passing it over to and integrating with Raj and his team in the Center for Interprofessional Education with the Thriving Together practice. So I'll pass it over to Raj. Thank you.
Thank you, Liz. Hello to everyone. Thanks for braving the cold. Welcome to everyone online. I see we have a robust group of folks, so it's really wonderful to be here. I'm really honored and pleased to have been asked to be here by Ed and by Alexandra, and really it's just wonderful to partner with Liz as we try to take you and present what we call 2 case examples of what a learning health system could look like, both at a system level and on the front lines. So I'm always inspired by Liz's story of how she brought all of these different units together. And it's a very common story. You're going to see some common themes in the story I'm about to tell you. If there are 3 things about thriving together that I would love for you to take away, the first is that we are doing real frontline work. We're working with true interprofessional teams in the healthcare system. Our goal was to do this at the ground to see what this would be like so that we could start to bubble this up to the system. Number 2 is we are using data that already exists in the system, but you heard from Liz, lives in these silos which create friction. We're using that data to drive improvement at the front line, which is obviously a core value of the LHS. And number 3, our goal with working with these teams is not to tell them what to do, but to use this approach to build leaders in those teams that will then transmit a different culture of interprofessional teamwork. So it's culture work, it's data work, and it's frontline work. And those are the 3 things that really we've held as core values for thriving together. A little bit, as Liz gave you a history, I'll give you a little history of our center. It's now branded as the Center for Interprofessional Practice and Education. And what you're going to hear today is exactly why we are now rebranding to work on practice in addition to education. We were founded in 2015 as part of the Third Century Initiative grants as a joint venture between the Provost's office and 10 health science colleges and schools across our 3 campuses in Ann Arbor, Flint, and Dearborn that focus on health and healthcare education. And you see those schools listed below. Our mission is to innovate. We believe this is innovative work and implement interprofessional practice and education. When you hear the word IPE, the P is for practice now. And this is a national moniker now. So it's interprofessional practice and education. And our goal is to improve the quintuple aims of health, as you heard from Liz. We're all working on this. However, we are not a Michigan medicine unit. We are a provost office unit that then works with the 10 deans and the provost as well. So we had to actually knock on the door of Michigan medicine and say, hey, could we add value to what you're doing? And I want to tell you a little bit of that story as to why the door opened a little bit first and now is wide open for us to do work in that setting. The first is we said that we will bring frameworks. Do you know that there are interprofessional practice and education competencies? And it was amazing. I went on this listening tour and all of our leaders, not one of them had heard about our center, even though we had been in existence for 7 years. And not one of them had heard that there were actually competencies for interprofessional practice. Now, of course, physicians, nurses, social workers, dentists, hygienists, physical therapy, OT, these are all part of Michigan medicine. And yet we're still educating people in silos. We're still doing training using HR in our professional silos. And so no one had heard that we had 5 competencies. And so we said, we'll bring 5 competencies as a framework for education and training. They said, oh, that's interesting. I also said, we have adopted a way of looking at how teams function at the front line. And we adopted Lencioni's 5 dysfunctions of team framework that you see here. And there are 5 behaviors that build from a foundational level right up to the top that he observed in both functional and dysfunctional teams, especially those that cross disciplines, which is everything in the health system crosses disciplines. Trust, the ability to actually have that kind of environment where you're vulnerable and everyone trusts each other. Being able to manage conflict without dysfunction, which means that you've got a psychologically safe environment in those teams. Then moving up to commitment, the ability for people to recognize the directions they're moving, there's clarity of decision making, and then people are committed going forward. The 4th highest level is accountability, which is about really being in agreement to the direction we're moving and then being able to call out when we're not meeting our direction for some reason, individuals or groups. And then finally, results. And we always talk about teams and we say, oh, this team's a great team. Look at the results they're delivering. This team is not so great. Look at the results they're not delivering. And we focus at the tip of this pyramid. And Lencioni said, but there is so much depth, just like the tip of an iceberg, of other things that may be going on, yet we're obsessed about results. Results don't happen unless the other 4 levels are actually working well. So we have adopted this framework. We brought it to the health system, and they said, oh, that's interesting. We've used different models, and it was interesting that there are probably 6 different models of teamwork that our single health system use. We haven't even agreed upon what the model of teamwork is. And we said, I think we should use both competencies and this teamwork model to be able to get us to look at teamwork with a different lens. And we presented it as an opportunity. And we brought data that showed that health systems with strong teamwork actually fared better during the pandemic than other health systems. If you look at sort of national data, there was a big drop in well-being and the culture of belonging and how people felt at work and outcomes that happened after the pandemic. And this was in a majority of health systems. But there was a small number of health systems that actually improved in all of those metrics during and after the pandemic. And those teamworks, those health systems had one unifying factor. They felt like they were working in great teams before the pandemic hit. And this has been identified as part of qualitative data and interviews that people have published afterwards. And you can see that it's here as well. So we said there's an opportunity here. We were one, unfortunately, that plummeted after the pandemic. And we were also not recovering as well as other health systems were after the pandemic. So there was something fundamental that was going on in our health system. And of course, at the same time, there was a new strategic plan that was called BASE, and now it's called BASE Plus and BASE Plus Growth and Bold Future. And if you look at the different elements of BASE, teamwork is an essential ingredient to each of these. So there's belonging, access, safety, and quality and experience, and all of those require great interprofessional teamwork, and they get lifted. And so we started talking about this, saying, and we feel that our ideas are aligned with your system strategy. And so the door started opening a little bit wider at that point. And then we started bringing data. And we said, look at all this data we collect in the system and look at how hard it is to actually see it horizontally. Everyone is seeing it vertically. And as Liz gave this great story about that unit that had been visited by 10 different horizontal units to work on well-being, to work on safety problems, to work on health and health disparities, and to work on what their IT system was breaking. And they are overwhelmed. This was part of our listening tour. They said, I can't tell you how many people have been coming to our unit in this X clinic over the last 2 years. Can you guys get your act together? Because we're exhausted. The copier is still broken and we need to fix that. That's part of our list that we need to do. So we brought all of the data and we said, okay, let's look at the dashboard that brings all of this data so a single unit can see all of these team sensitive issues at once. That dashboard doesn't exist. I'm saying that half facetiously because what we did is we did the same thing Liz did. We went to the School of Public Health and we said, you guys have got HMP students. We went to the Michigan Medicine Administrative Fellows Program. We said, we'll take a fellow for 2 years. And they did what we call crosswalking of the data. It's a manual process. So as we're starting to think about the LHS, we've got a huge hill to climb in terms of data for a unit to see everything that's relevant to them. If they're just seeing one level of data, it's just one. And so we started bringing all of them. And you can't imagine the number of administrative leaders who said, I've never seen this data lined up like this before in decades of doing this work. So we did kind of an exploratory data analysis and we used 2023 and 2024 data. And we started showing that there was some relationship between teamwork and patient safety and workplace safety, and that teamwork in both other institutions and ours was a key driver. The answers to those questions on teamwork was a key driver to whether someone chose to stay at the University of Michigan or not, and whether they had open positions that could be filled or not. Like, this data exists in our system and no one had seen it that way. We partnered with Press Ganey, who really helped us articulate these arguments with these different health systems. But again, the data lives in silos and the units don't always work together to improve teamwork. So we said, well, let us do what Liz did. Let's convene those who own the quintuple aims of health. And we created a systems transformation committee that then started meeting and started committing to doing work together. And we came up with a demonstration project. And that's what we're in the middle of right now. The demonstration project was saying we would use evidence-informed methodology. We'd leverage the expertise of all of these 6 units, horizontal units that you see there. We would work with our center, which lives outside of the health system, but we would convene them as partners to improve interprofessional teamwork through local action plans. And we called our intervention ACT. A stands for assessment. C stands for coaching and creating this champion of leaders to change culture. And T stands for customized, tailored training and development. Not everyone needs to do every module that you get on your whatever the set of CME and stuff that we need to do, but shouldn't we tailor what matters based on data that we already have in the system? And we said there's evidence for this. And we actually interviewed system leaders at 3 health systems across the country that have done this from a top down. We have decided we haven't yet done this from a top-down approach. So we said, okay, we'll work at the front lines and we'll do it organically and see whether we can demonstrate that this adds value to those teams. But there's a lot of robust data that shows that the ACT model has a strong evidence in terms of improving interprofessional teamwork and improving all those other outcomes that you see there. And the way it works is it's very simple. We use the data, we then talk to leaders, and then we go and we find which are the units that are struggling with this, with the crosswalking of the data, and then we deploy the ACT model in those units. And what we've been offered to do is to work in 1 inpatient unit and 1 ambulatory unit. And both of those units have been identified. We're already starting to do the deep work in the clinic setting, and we're starting to start our work in the inpatient setting as well. And they will be familiar to you all as you start hearing about this more and more. There's a whole data approach that I won't take you through, but suffice it to say, we needed to start with the data and set up a methodology to understand what would qualify as thriving units and what would qualify as struggling units. And we use those then to really map out our 293 units, I think we have across our health system We rank ordered them and we started working at the bottom 20 to see who might be interested in working on this and where do leaders want to point us. So these decisions have been made from the triad, executive triad leadership, through all the different administrative leadership. And now we've gotten buy-in from the ground level to do this work. This is our timeline. It's a long timeline that you see here. And we've got a lot of next steps that we need to do. Like I said, we're working deeply now in one inpatient and outpatient setting. We are launching the coaching and the support for each of the champions team. We're doing the customized training and development, and we're co-developing the metrics with each of these units. What matters to them should be as important as what matters to David Miller as it relates to this different data. And so we kind of see ourselves as a neutral bridge between the academic environment and the health system environment to allow us to have those conversations at the front line. There's a lot of slides I'm just going to flip through so you can see what these different graphs look like that we show people. This is a primary care clinic report data snapshot. This is what we're sharing we're working in primary care as one of the ambulatory sites. You can see how we map observed behaviors to the IPE competencies and the 5 behaviors there so people can see where their gaps are and where they're doing well. And we are then bringing the C part, which is we've adopted the 3 pillars of leadership. We've commissioned an external agency to actually come to these different settings and do leadership training for this champions team at each of the units so they can be the leaders of culture. And this is a unit that this is a company we've worked with in the dean's office and in the provost's office for about 8 years now, and has really resulted in impactful team coaching, not just individual coaching, team coaching. And then we just like Liz has done, we've combed the entire university for these resources. There is a bewildering array of things that people can do to improve teamwork. And yet everyone says, I have no idea how to get access to those. I know there's something over in the School of Public Health. Yep, I've heard of the Center for Positive Organizations. I have no idea how to do that. People have heard of these things. And they say, this is the double-edged sword of being at Michigan. Rich array of resources, no way to get there. And so we, just like Liz has done, we've built this repository of team-sensitive resources that will improve teamwork and really team culture improvement. And we've mapped them to the competencies, and we're now tailoring it for these different units. So that's really, in a nutshell, the 2 cases. We believe there are so many elements of the LHS which are embedded into both of our work, even though we didn't bring in an LHS scholar into our work, which to us means that you are absolutely on the right track, but yet there are key challenges. The questions that Liz and I and Ed and Alexandra and Chuck and others are probably contemplating is, why isn't it at scale right now? Why are we working at the front lines? Why is there so much friction in bringing people together? Why is there pushback? Because that's not for negative intention. It's because we're organized a certain way, and it's because we've been raised a certain way. So I think one of the most important things we can think about as a LHS, if we think that this is the model to scale, is we need to spend a lot more effort on culture. What is the culture that gets in the way of the learning health system? And how can we do culture work while we do also the academic and the transactional and the really hard frontline and system level work to make this happen? So thanks, and we look forward to all your great questions.
Liz, Raj, thank you so much. So for the past 2 years, I have had this role as the Learning Health System Clinical Champion. And someday I hope to come to this forum and tell you everything about what's happened over the time. There's a lot of learning that went into this. But there's a couple of messages that I really have been trying, I've been forming and then now trying to put them out. The first thing is that at a place like Michigan Medicine, we are a learning health system. Oh, we always thought we were trying to become a learning system. We are a learning health system. It's just one that doesn't function very well. What I mean by that is that, when you sit down and talk to people and tell them what a learning health system is, it says, well, we get people together, we decide what data we need to collect, we learn from the data, and then we act on it. People can show me places where they do that, one place or another, this piece, that piece. We talk about the broken circle, the idea that people are doing these things, but they're not carrying forward through the process that leads to the improvements we want to see. That is the very hallmark of a learning health system. So my role here has been, to a great extent, of just trying to spread the word, champion a learning health system. So trying to see and help people understand where we're using learning health system ideas and where we could use them better. And I think this is one of the reasons I really wanted to have this talk today, because I think this is a classic example. So, let's see. How do we get to my slide? There we go. Okay. It's kind of falling apart there. Okay. Well, I'll tell you what it's supposed to say. So I think this presentation shows us the really broad usage of the LHS methodology. And LHS is designed to improve healthcare outcomes. We generally think that this means gathering data from clinical encounters and patient outcomes. But these are examples of the LHS functioning at the system level and at the clinic level, and then we go to the patient level. So the M-Integrate idea is, let's form a learning community of people that are interested in providing resources that help teams thrive. That's our learning community. We bring ourselves together. We decide what metrics are going to help us understand that we're doing well. We're going to put this into practice, and then we're going to learn from what happens and then improve how we are improving other people's services. Then we think about the members of that learning community. I'm one of the members. Raj is one of the members. Well, even the Office of Wellbeing, which is organizing it, is one of the members. Liz is one of the members. So each of us has the function that we do within the structure of M-Integrate. So when we think about the thriving together, that is its own learning community within the learning community of the learning community of M-Integrate. And there, the learning community is the team, Raj's team, the people that he puts together to help improve other teams. And then from there, we see how that learning community fosters the next level of learning community, which is the clinic. These are the people I've been working with a lot as well. We sit down with clinicians, with people who do the administrative work in those clinics. We bring in patients, and we talk about how we can work together. What are the goals that we should set to define who our population is, and then understand how we're treating them and how we can improve care. So one learning health system fosters the other, but a classic model, at least I came into this with, of just, it's a bunch of clinicians thinking about working with their patients, thinking about the care they're giving. This is very eye-opening to me about how this can work. So as another example, gosh, guys, I don't know where all these lines all over the thing came from, but we won't pay attention to that. So we think about the idea of M-Integrate, thriving together, the LHS clinical champion, so forth, are creating, improving, and developing all those things. The socio-technological infrastructure that, if you've read Chuck Friedman's articles, you know very well exactly what I'm talking about. That's the cultural piece. That's the technological piece. I do want to say that when I took this position, people said to me, you're never going to convince them to hire another 100 IT people to do this thing you want to do. So it turns out that I don't know how many more IT people we need to really function as a learning health system, but that is definitely not the issue. Raj hit it right on the head. What's the quote, Raj? The only thing you can't mandate is culture. How's that?
The only thing leaders cannot delegate is culture.
Is culture. So culture is what it's about. The biggest barrier that I have is that barrier been getting the hits to put together the things we need to do to collect data? Has it been the analyzing of the data? No, it's been getting people to come to the meetings so we can talk about, form that learning community and talk about what we want to do. So we're trying to build that social infrastructure and working with the technological infrastructure. And I think that's what everybody here is trying to do, but at those different levels, functioning to bring the teams together that will function to bring the team together that will then function better with the patient care. And so how is M-Integrate going to understand how it's doing as it goes through the cyclone of improvement? Well, the data that it's going to collect is going to be based on the other cyclones it creates. Cyclone's a good thing here. I know in lean, cyclone's a mess. But when we talk about our cyclone diagram, it means, the continuous cycles of improvement. So is M-Integrate bringing members together that will help teams go through cycles of improvement? That's how we'll know that we're improving. And if we're not, we have to learn from that data, and then we have to get better. Going down now to where LHS, and the LHS Clinical Champion and the Department of LHS, and the idea of a clinical implementation unit for LHS fits into something like M-Integrate. Where does it fit into the thriving team? Well, when I first heard about this, I said to Raj, you get these teams to thrive, but what do they thrive around? What is it they're doing now that they want to work together and they want to coordinate together? What are they doing? So they have to get together, decide what they want to work on, and decide if, gather the data, learn from it, and decide how they make it better, right? Learning health system. So the learning health system development is an improvement tool and part of thriving teams. What does a learning health system do? It increases engagement among members of the team. One of the problems we have in the clinical teams that we have a lot of clinical teams that aren't really clinical teams. They are people doing their jobs, wishing the people around them was doing a better job and paying attention to them, and just not functioning as a team. And that's the learning health system gets people to sit down together. And I've just seen this over and over. How do we work together to try and make things better? It breaks down those silos. It decreases the chaos that goes on sometimes in the clinical setting, and increases focus on things that matter rather than checking off boxes and that kind of thing. Let's talk about what we really want to talk about, the thing that we came here to do, the thing that we spent 100 years in medical school and residency and training and all those kind of things to learn how to do, nursing school, physical therapy school, et cetera, how do we actually bring value to that kind of work? So, we all know about the problem of burnout. We talked about a little bit here today. And LHS addresses a lot of these problems of burnout. One of the main things that's talked about is the loss of autonomy. And LHS has to get you opportunities to work with your team to chart the course of your team. It brings autonomy back into your practice. People say a sense of powerlessness. And LHS is very empowering because you influence the decision making. There's a lot of administrative tasks that are low value. Well, the idea of an LHS is let's talk about the work we really want to do and bring value into that work, like I just said. EHR, if you make a list of 10 things that are really causing physician burnout these days, 8 of them are EHR. No, maybe not 8, but it is true that at least 3 out of the top 10 that I saw are the electronic health record, the electronic medical record. So LHS is designed to make the electronic medical record work for you. If you have it going right, if you're using the right tools, it actually decreases your work and it decreases the problems you have with the electronic medical record, and it helps you function within that environment. And someday we can talk about that in more detail. And finally, in this environment, in an academic center like Michigan, one of the things that is very stressful for our most clinical faculty is that they know that if they want to climb the ladder, they have to be academically productive. The medical center has taken some steps to try and change that, but believe me, as a department chair, I saw that no matter how they described it and how they explained it, it all came down to the same thing. We want to know about your academic productivity. What are you getting out there? What are you publishing? And if you're seeing patients 9.5 days a week, and then you go home and you do your documentation and then take care of your patient messages, and maybe you want to talk to your spouse and kids a little bit too, right? How do you do that? So the LHS creates a framework for researchers and clinicians to work together. You have clinical researchers who say that nobody ever recruits patients for us. Well, here's your patient. Here, I pushed a few buttons. My LHS framework popped out the patients that you're looking for. And that can help everybody become more academically productive, which around here is a big boon for well-being, satisfaction. So that's how LHS fits into this model, and that's how this model shows you a picture of levels of LHS. I thought would be fascinating for people to hear about, and that brings us to questions. Alexander.
Okay, well, that was a really fascinating set of presentations. I'm going to ask a couple of questions at the beginning of our Q&A just to open the discussion up, and then I will be curious to hear what's on your minds as well. I also have an eye on the chat, so if you are sitting on a question, please feel free to pop it in there and I will weave it into the discussion. So one of the things that I appreciated about Ed's remarks capping off the presentations today was that he talked about the potential of the learning health system. A lot of us in this room, we work on learning health systems because we know that it has a big promise, and we seek to achieve that promise in real world contexts, including clinical contexts, educational contexts, research contexts. The challenge really is in making it work in these everyday contexts. And that's what I think was so fabulous about the remarks that Raj and Liz shared with us. So I want to start by posing a question to Liz, and then Ed and Raj, you may also want to address this as well. You mentioned that there were certain barriers and challenges to integration that you encountered when you were leading the formation of M-Integrate. One of them, for example, was sort of territorialism and the recognition that people were doing the same thing in different places. So I'm wondering if you could talk a little bit about the nuts and bolts of your own internal culture change and what lessons that might have for the rest of us who are seeking to lead culture change initiatives.
Happy to. Is this on already? Yeah.
Yep.
Okay. So I think, there's a couple pieces here. And the first thing I'll say is that we're still doing it. So, we're still changing culture around this. We're still getting buy-in. We're still bringing people together. And it's not an exhaustive list, right? Like I said, there's a lot of other horizontals that are not there. And our goal is that we grow in that space. I think the first thing to start with is this idea of assuming positive intent. I think everybody that works in this space wants to really help the people that they're trying to help and has an eye to do that. I think sometimes when people hear about a new initiative, they think you're creating redundancy. Our team already does this. We don't need this. And I think part of the aha moment in one of our meetings was actually when people heard from other teams that they were doing really similar things, because all of these groups have been sanctioned to do the work they're doing, and to realize that in some ways we're duplicating one another's efforts, which means we're not being as impactful as we could be. A lot of us feel really stretched thin, right? And we don't have the capacity that we would like to be able to serve as many people as we can. I mentioned that was also a problem. And so when we could frame it as, the goal here is not to make you smaller, it's to make you bigger. The goal here is to make you more effective, is to make you able to do what you do even better. And if there is a Venn diagram area where there's overlap between some of these, maybe we can talk about what makes most sense. For example, I'll just give a small example. We recently learned that there are two programs with the same name. They don't do the same thing, but they have the exact same name. And you can imagine sort of the reaction of the two areas when they figured that out. My response was we should celebrate that because we didn't know that before. But surely somebody on the front line is going to stumble across those two programs and not understand the difference. So this is a great learning opportunity for us to identify them. But I think it's a really natural response at first to be wait a minute, you have a program named that and I have a program named that, and what does that mean, right? And so I think part of it also, and we had a conversation with a different team this morning where we talked a lot about team and belonging is building, and as Raj really mentioned, in the 5 dysfunctions of a team, that core base is trust. And in some places we've built it, and in some places we're building it, and in some places we need to build it and it's not there. And so it's sort of we're on our own iterative pathway with each partner here in that building of the trust. And then I think everything flows from there. But I'd love to hear, because both of you have been integral in many, if not all of these discussions, so I'd love to hear your reflections on that too.
I love that, Liz, and I echo everything that you said, especially the concept of assuming positive intent. We had exactly the same reaction when we started bringing together the Office of Wellbeing, the Office of Health Advancement, Faculty Affairs, HR, Patient Safety. All of these different units had worked often in dyads together, but never as a group of 6. And they started talking. Our first conversations were very much well, I've been doing that for years. And wait a minute, you've got that too? And you do leadership development program too? And initially there was a little bit, but then it softened over a few months of coming together. And so I think the only additional thing I will add to Liz's great comments is something we did in our center that we talk about a lot is that if we're going to, I love how Ed put it, if we're going to be a learning community, working within a learning community, partnering with a learning community, then we have to walk the walk of the values that we want to see. So we as a center need to work really well as a team. And you saw that C part of ACT that I just glanced over, but that has been deep 8 years of work with this other consulting group that has brought in the values of teamwork. And we work on 3 pillars. We work on, and this is in our centers teams, we work on self-mastery. What mood and what type are we, and how do we understand each other and bring empathy to our interactions? We work on social competence. We do deliberate training in our center on how we work together and resolve disagreements. And we do it through workshops and seminars and through case studies. We're practice partners with each other. And then we do education and training ourselves. So I said the ACT model has to be part of what we do so that we can bring it to others. And I think when we started our first meetings with our frontline ambulatory care clinic and inpatient clinic, we disarmingly said, okay, we're going to do a mood check with you, which is what we do in our center. Every time we meet, we say, what mood are we bringing to the table? It's part of emotional self-mastery and competence. And everyone was stunned. I mean, you had an ambulatory clinic unit director, you had a nursing educator, you had an MA sort of front desk staff. But it only was stunning for 5 minutes. And then they started saying these words. And now we've done it like 6, 7 times. And they're walking in, they're using their card, and they're like leaning into this. I think we're tapping into something people are yearning for in teams. It's not just what you do together, but it's about how you feel about each other as in relation to each other. And how then can you hold yourself accountable? How can you resolve differences built upon that foundation? So that is kind of taking you into the weeds, but we felt like we had to do that work first before we could bring it to others.
Just recently, we had the first large meeting of a learning community that I'm working with, and it was, people were just so excited about it. And I think, when you talk about how you move these things along, you really have to kind of push people into the deep end of the pool, to get them swimming, because once they're in it, it becomes magical. They really love it. They really can see the value of it and that kind of thing. I'm going to quote Chuck, as he told us that when he got hired, he sat down with Jim Wallscroft, the dean, and he said, "When are you going to declare this place learning health system?" And the dean told him, "That's the surest way to make sure it's not going to happen." Can you do this from the top down? I always think about, my whole approach to this has been ground up. You've got to work at the ground level to get people to understand, and then they bubble it up to their leaders, who start to bubble it up to their leaders. I think that's even in the sense of like integrate, it's getting the individuals that are not the individual clinicians, but the groups themselves who are feeling energized by the whole integrate concept. So you have to get people into it to do that. Now, does it help to have some top-down support? Maybe not command, but support. Yes, top-down support would be very helpful. And that's a project that I've been working on in terms of can we get that environment more verbalized by some of our leaders in terms of getting into these kind of concepts. But I think that's, I always think culture has to build up from the bottom.
And maybe I could just add one thing to add. I'm not disagreeing. I think culture has to be at the ground level. But Liz said something at our earlier meeting today that really stuck with me. We can all recite BASE now, right? And BASE, what does the B stand for? It's belonging. And Liz said, what a remarkable place that the system strategy starts with a cultural value of belonging. Maybe we should celebrate that, and maybe we need to lean into that a lot more. Maybe if we started talking about culture, maybe they don't have to dictate this is an LHS, but if they said the values we care about most above all is how we belong and how we work together, and those cultures, I imagine, are enabling factors for an LHS. Because if it's not done, if cultural work is not done at the leader level, I worry, frankly, that LHS will only get so far until it comes up against something. And that something could be just reinforced behaviors that are antithetical to what we're trying to do.
I think there's no question, you hit something very important, Raj. People sense what their leaders value. Whether they verbalize it as being an order or how they verbalize it, people sense what their leaders value. And that's going to be what they're most interested in doing, because they know that's the thing that's going to help them rise the best. How do we get leaders to value something that we know that our ground providers value? That's the work we have to keep doing.
You have a really good panel when they sort of answer the question that you were going to ask next before you could even really get it out. I really appreciated hearing your consideration. You're all in senior roles, you're in administrative leadership roles. So there is I imagine it's a real live problem of how do you lead from the top down in a way that reinforces a culture of belonging and a sense of grassroots action and a sense of ownership amongst all of the groups that you're seeking to build a coalition with. I will give a shout out to Chuck, who's recently worked with colleagues to develop a typology of learning health systems. The type of learning health system that we build most frequently here at the university and that the Department of Learning Health Sciences kind of breathes into in terms of its philosophy is the participative LHS, which really has a goal of broader institutional culture change or systems culture change, and does that through grassroots action. But when we decide or kind of have a formal or informal institutional commitment to that type of philosophical approach to learning health system building, it has these really interesting implications for how to lead in that environment. So I certainly appreciated your reflections on that. I will also say, and here's where I'll turn to one of the really good questions that we have in the chat. We have spent a lot of time talking about the higher levels and some of the leadership dilemmas, but we have a colleague in the Department of Learning Health Sciences who's part of our Melstar Learning Health System Embedded Scientists Initiative, Greg Merritt, who has asked, the people who have the most at stake for success, as you all describe, are the patients and those who love and care for them. So how are your plans, including those with lived expertise, in your learning health system programs that you have created or are creating? He continues, how might partnering with patients help and give yet another lens and expertise on your work? One potential way to approach this might also be thinking about absent stakeholders or silent stakeholders in your process, or even times when you've had real surprises around stakeholders.
Yeah, so I'll just make a few comments on this. One, I don't know if you just plugged a belonging pearl, but you did. And a pearl a couple weeks ago was this idea of who's at the table and who has a voice is really important, and also who's not at the table and who's not being asked to use their voice is also really important. There's a lot of layers to that question, and so I'll just speak to a couple of them. One is we definitely have, as we mentioned, stakeholders that are not there yet. And so in addition to patients, so we do have patient experience, but we do not have a patient yet. We also don't have learners directly represented yet. And I think that, to Raj's point, is a really important piece in this, because I think they often feel, not only, as Raj has mentioned, when they come, the wonderful skills they've been taught aren't being used, but they also see that their team is so overwhelmed and so overloaded that they don't even remember the learner's name, after 2 weeks with them because they didn't spend enough time with them, right? And so I think they're seeing the downstream consequences of this friction in the system in a real way, and I would really like to have their involvement too. So there is this iterative process, and I think there's a lot. I mean, we could probably sit here for 30 minutes and identify a bunch of other stakeholders that should be part of this that aren't yet. And so I'm hoping that this grows, and I'm hoping that we can continue to grow it. But one of the things I do want to call out is that the reason we have 2 assessments is very important, because if we just gave a leader assessment, our leaders are fantastic. And there is a reason that I still and will always practice medicine. It's that my experience as a primary care doctor is very different than what I hear in the meetings I sit in. And if I didn't also go practice in clinic, I wouldn't really understand exactly what's happening. And I think it's really, really important to have that. We need to have our frontline team. So the team assessment goes to everyone on the team so that they have their opportunity to voice what's happening. And then the leader assessment is their perception. And again, this comes down to this sense, if we really value belonging, we value belonging for everybody. And that includes our leaders and assuming positive intent of them and the multiple competing priorities that they have and the demands they're trying to meet. And being, a leader at that level is very challenging. And so we want to make sure we are supporting the leaders in meeting their goals, and we are supporting the front line in understanding where there are gaps there as well. So I think that piece is really important in getting that frontline voice to be part of that.
Yeah, I think like Liz's unit, we have done similar approaches to trying to include the patient voice in everything that we do. Even before we launched Thriving Together, we built some of the early experiential courses in full partnership with the Office of Patient Experience. And so our center actually has had almost a 9-year relationship with OPE, which has really become deep. And then when we started Thriving Together, they were really essential in co-producing. And they're some of our best observers when we go into the clinic and do the assessment phase. They see things that we may not see as clinicians, or even people from other professions may not see. So that has been helpful. But I think there's also national dialogue about offices of patient experience, and are they fully representative of all of what a patient understands. So when we started in our assessment phase, when we're there observing the clinic in the inpatient setting, we're actually spending time with patients and asking them questions about what their experience with the team is like. And there are big gaps in what we think patients want among our teams and what both those great points that Greg made.
Raj, you remind me of something I always like to say: if you're making a revolution, you have to get the children. So, how do we get into the professional schools and get some of these ideas? One of the ideas I think that we really need to help people with is this idea of more patient voice. I think everybody knows that patient voice is a important part of a learning community. Anybody who's taken any courses in the department will have heard that. I talk to people about that all the time, and I always get a wince when I start talking about that. People are a little afraid to let patients into the inner circle. So that's a cultural piece I've been working with people, and I tell them what's different about learning health system? And I tell them that is one of the things that we feel is very different, that the patient voice becomes a very important piece. So we're working on it.
Thank you. I want to open it up to those of us in the room for additional questions.
Good to go. Hi, Alex Holloway, second-year PhD student in Hills. I'm very fond of quantitative methods and causal inference, and I think one of the things LHSs need to sort of adopt is kind of causal inference framework when they're analyzing data. It's not enough to just measure something and claim that whatever you did had an effect on that outcome. So how do you think about these really complex things you're measuring, teamwork, satisfaction, and how the things you're doing are actually affecting outcomes?
Great question.
I think it's a terrific question. I'll share, we don't have great answers to that, but I'll share just like the briefest of how we're trying to approach this. We have brought quantitative scientists onto our team to help us with that. And they have pushed us to create a methodology where we're constantly doing both quantitative and qualitative pulse of the team over a year. So we're doing it monthly. And so we may not, we're hoping that will start to detect things that may be able to help us imply causality. And I think sometimes the causality comes through the qualitative observations and the follow-up questions, the why questions. Why are you doing it this way now? What led you there? And we have to be ambivalent. To quote one of my friends, like we have to be ambivalent when we ask those questions. So we're also trying to make sure that we're appropriately at arm's length from the actual measurement of these. But we would welcome real scholars in this realm to help advise us, because I think we're accountable to the health system. They're saying, we need to know if this works, if we're even going to scale you guys up or not. And we have to be able to answer that with rigor, not just with, believe me, it worked.
It is hard enough understanding, being sure that the medication you're giving a patient is the thing that's actually reducing their pain, or et cetera, et cetera, et cetera, et cetera. So the measuring these kind of things is really, really a challenge. One of the things that when I talk to people about, how the medical center is acting as learning health system, we like to measure things like readmission. And what intervention can we do that decreases readmission to the point where we are sure that that is the thing that we should continue to invest in, because that's the thing that changed the course of readmission. It's difficult. Sometimes I think, like Rajesh saying, if you look at patterns over time, what happens when you pull it back? That's what I do with medications. Let's take it off for a while. Let's see what happens. Is that cruel? Yes, but it works. So yeah, it's challenging.
Yeah, thank you so much for your question. And I just want to pull on two threads. One is I always try to hire really smart people to be around. And so we hired an organizational psychologist who is helping us think about how to do this, and then partnering with the School of Public Health. And, I think that this field in general, not only sort of how do we improve the work environment, but to the end of the experience that people are having, and how do we quantify the experience that people are having, and is that experience impacted solely by the organization they are in, or what individual factors are conflating that experience? And, you can go down a really long rabbit hole. There's like a national debate right now around, are burnout and depression the same thing? My position is they are not, but they, there's like dialogue there. And so, and I'm sharing this with you because a separate project we did is survey our research faculty on their burnout levels, and their correlates of burnout, not their drivers, but their correlates, right, with their burnout, and have spent time with every chair going through their data. And every chair gives us a similar look for the first 5 minutes of the meeting, which is sort of like, this isn't the most, robust causal interpretive data I've ever seen. And it's like, yeah, you're right. And how do we still have a conversation? And how do we still help people? And how do we use it to start conversations? And so what I love about Raj's model is how many conversations they have. And I think of some of this data as a little bit more smoke. And when there's smoke, then it points us in a direction to go look for fire. And then you go talk to people and you try to better understand. But I also think that this is a really important field that we need to develop so that we can really understand what's driving turnover, right? What's driving retention, some of these things. And then to pull on a thread that Ed said, which I think is really important, in order to meaningfully advance this field and better understand what we're looking at, we need to also meaningfully stop measuring other things, right? So there's a lot of stuff we're measuring right now that we can impact that, is overloading our teams, that are old measures that haven't been retired, that, maybe that we aren't even required to do externally from CMS, but we haven't stopped doing it. And so I also think about our cognitive bandwidth and what do we need to stop looking at so that we can be really thoughtful in trying to understand how we know we're making a difference or where to look next.
Could I just add one other thing, which is I think the opportunity we have at an academic institution compared to a health system that may not have a university around it. And that is, we have this baked in values of questioning our own assumptions that may have been long held and that may be standing on the flimsiest of evidence as it relates to causal inference or attribution. And I love the fact that at an academic organization, we can actually say, are we sure? And to actually move forward, not in a necessarily a corporate way, but to move forward in a way that says this is an experiment. We actually may not see what we think is happening. We pulled some data on some of these clinics that we thought, okay, for sure, turnover was going to be much higher in these places that had deep culture. And would you believe that there were a couple of clinics that had really difficult other metrics, but their turnover rate was amazing? Like really like national role models, like people were fiercely committed to that place. And so that got us to say, okay, maybe we're not going to see everything we think we're going to see. But it was in an organization like ours that we didn't just ignore it. We kind of said, okay, let's put a pin in that. We need to go back there and figure out what's going on there, that despite what's going around them, they're sticking with them.
I think one of the real challenges of metrics is the time of the long-term metric. For really understand if you've had an impact in the clinical situation, how long do you follow a patient? In my field in rehabilitation, they go home and, do we know how they're doing 2 years later? Only if they show up in clinic. If they don't, we don't know. So a lot of times we do things and we measure what happens 6 months later, and then we turn our attention to something else. The real improvement comes from knowing that is something that was sustained. And that's a very big challenge of measurement.
Thank you. This is a really fascinating discussion. Thank you, Alex, for that question. There's a lot of important practical wisdom here too that's really harmonious with learning health system principles, which is really starting where you are, even if you feel like you're not ready yet, and making that iterative learning process work for you. Maybe you don't have the perfect survey that allows sophisticated causal inference, but maybe you don't need that yet. Maybe you just need something. And that's one of the things that sometimes really pops out as a difference between discovery research and learning health system science. As this discussion has gone on, there's actually been a really fascinating continuation of the discussion about patient integration into learning health system initiatives that has continued in the chat. To elevate some of the comments, the theme is that there is more we can do to integrate patients and loved ones throughout these different initiatives in the health system. It is something that could be an ongoing part of the conversation that our department has with other parts of the university. So more to come
amplify
there.
the word you use there is patients and loved ones, because we had a great discussion yesterday about one of our colleagues in our interprofessional space who's created a disability education curricula, an educational experience for multiple different health professionals. It's an interprofessional course. And caregivers are an essential part of that course with patients. And it really struck me, how often are we in our different professions paying attention to the caregivers around them? And he shared stories about how sometimes caregivers are considered annoying by clinicians. They're voicing up when I just want to focus on the patient, and how culturally anathema that is to the reality of what those patients and their caregivers face. So I loved that you included that in the moniker there.
Thank you. I think it's really important to think expansively about who is accompanying someone through a healthcare journey. With that, I want to bring our session to a close.